Now let's jump back into our afternoon sessions. Kicking things off, we have Amy Jaramillo, who will be discussing how to use SOT in treating neurodegenerative diseases. Please join me in giving her a warm welcome to the stage. Take it away, Amy.
All right, so back from lunch. Let me start by saying I do not intend to kill you with a million slides. That's not my style. We'll go through about 15 slides. Here's my objective. I have been using SOTs for infection control for about 3 years, and I've had some very impressive success. So success for me is disease control in very difficult to control diseases. And what I would tell you in my experience, oftentimes we are overlooking the role of infections that are considered to be chronic and oftentimes considered to be unimportant. And by overlooking those infections, I think we're seeing a lot of illnesses. For me, this is a pretty exciting time in medicine, right, to be clinical. And the reason is we didn't have a lot of options until recently. So whether we're talking about oncology and all of the conversations earlier this morning, or whether we're talking about Lyme, herpetics, parasites, we have been, I think, in a situation up until very recently where we didn't understand, identify, or look to treat the infections. And as a result, they led to a lot of diseases that we have all seen, not really looked necessarily for a cause for those diseases, expecting that they're just part of, I don't know, humankind, getting old, living day to day. Seeing now the role that these infections play in a lot of the diseases that we're seeing allows us to kind of reframe what we're doing and find solutions. And so again, I think about 3 years ago, before I was working with SOTs, and that's what I'd like to talk about. I'd like to talk about infections, the role that they play in neurodegenerative diseases as one, but many other diseases as well, and how I got to SOTs. So I'll start out by telling you that story. My name is Amy Jaramillo. I am the scientific director and strategist at BodyScience. And I would tell you, we did not start out looking to treat neurodegenerative diseases, largely because if you would have asked me 3 years ago, what I would have said is, I imagine the same thing that you would say, there are not a lot of solutions to control neurodegenerative diseases. So whether we're talking now about ALS, Parkinson's, Alzheimer's, multiple sclerosis, a handful of years ago, we did not really have good options. And in the absence of SOTs, our options continue to be fairly limited. And so I think there have been a tremendous number of new developments, especially since COVID, right? During COVID and what COVID left behind, which was an interesting understanding of immunology, right? So I think we watched a failure of infectious disease and immunology to understand virology, and over 6 million people, I mean, think about that, over 6 million people in the course of a couple of years recently died of a virus that we've already seen in the human population multiple times in the past. And so the question is, can we get a better handle on the types of infections that cause problems and lead to the kinds of diseases that we're seeing routinely? 2017, I had a functional practice I started in 2009. My background is science. I'm a cell biologist, scientist. I had somebody, a neurologist, that referred an ALS patient. I'd had 2 prior referrals for ALS that I turned away, telling both that I had no idea of what to do. I didn't understand the disease. I didn't think there were any treatment options or treatment solutions. And so even though I recognized at the time sending them back to neurology certainly was not going to allow for prolonged life or better outcome, the fact that I didn't have any understanding or any tools in my toolbox meant taking those folks on was going to be an unfair situation for them. 2017, I had somebody also diagnosed and decided, is it really true? These diseases are just not treatable. Like that's where we live from this point forward. That's where we are medicine-wise, technology-wise. We just kind of throw in the towel. The same place that we had been for a long time in oncology, which is why this morning I thought was so incredibly useful, right? A new toolbox and looking at oncology in a different way, in a way that didn't exist a decade ago, right? When genetics weren't so commonplace, and immunotherapy, immune modulating strategies versus chemotherapy, a strictly kill strategy. Before those new technologies, there were not a lot of options. I would tell you, in the realm of neurodegenerative diseases, we are looking at something similar. We are looking at treatable diseases that largely go untreated or undertreated. We are looking at diseases that respond to treatment. So 2017, I get somebody, and at that point I was seeing all kinds of unusual and difficult functional cases. I would imagine that's the one thing that probably ties everybody in this room together, right? If we didn't like really tough stuff, chances are we wouldn't be at this conference, right? So my guess, that's kind of the juice that we all run on. So 2017, I just decide, I mean, that's it. The question is, certainly it's not going to be any worse prognosis-wise, right? Let's take a look and kind of get a sense of what's going on. And I looked through and found a number of infections and chemical toxins and worked through them. 2019, all of the ALS symptoms had reversed. I sent him over to Duke. They have a list of reversals. They're the ones that can recognize a reversal. And sure enough, they recognized him as number 44 ALS reversal. Here's what I would tell you. Since then, we have 4 recognized ALS reversals, a very large number of ALS remissions. We've had tremendous success in Alzheimer's, Parkinson's, multiple sclerosis. And so the question becomes, how are we doing this? What's the magic trick? And what I would say is, it isn't. It's looking at existing infections that oftentimes, I don't think it's that they are overlooked. I think instead, oftentimes, they are underestimated. Going back to COVID, I think it gave us a much clearer understanding of immunology and infectious disease. And for me, and I imagine for you guys as well, it made this whole process a lot more fun, right? Actually seeing these infections and their role that they play. And then on the RGCC side, or SOT side, I don't think I would have the level of success that we have at the center if I didn't have those kinds of tools. 2020, I had somebody that started in the practice, advanced ALS, had been everywhere, and had Lyme, and had been diagnosed with Lyme. And by the time he came into my office, he had been on 2 years of an IV antibiotic regimen, and it was a persisters regimen, so it wasn't just antibiotics, it was a whole cluster of medications. I looked at the original labs looking at antibody titer levels. 2 years later, IV therapy, I look at the titers and I see the same numbers. What was very clear for me, I was not going to get involved with chronic diseases, Lyme, herpetic viruses, without the use of something where I could interact with the DNA, interact with the immune system, improve immune surveillance, sensitize. And so my objective was to switch from folks that were using a lot of approaches that clearly were not working, understand the etiology of these diseases, the infection component of it, the chemicals that are driving these kinds of infections, and then look to see if we could get disease control, and that's exactly what we got. Okay, so here is my objective for our talk today. I'm hoping to be able to give you an idea of when I'm using SOTs, what I'm doing before and after SOT in order to make things more effective than they would otherwise be. What I would use as my proof as far as, is this something reasonable to consider in your own practices? As far as I know, there aren't other centers that have even close to the kind of success that we have in neurodegenerative diseases, in addition to numerous other chronic diseases. And so what we have found from an outcome standpoint, some very impressive outcomes in diseases that I think we were all looking at a decade ago in kind of a black box concept. We don't know why they happen. We don't really have a sense of how to go after them. Ultimately, reframing that into the world of infectious diseases and coupling that with environmental toxins was the switch on our side to move people from this, who the heck knows what this disease is or how it's happening, to a position of, okay, it's these infections, and as titer levels come down, we expect to see more and more symptomatic control. Let me see if I have a clicker over here. Okay, so the power of infection control. Again, it allows us, and we were talking about oncology throughout the morning, the same can be said. It is not to say that there couldn't be genetic predispositions, but unless anticipation is 100%, meaning you have the genetic modification and you are 100% likely to get that disease if you live long enough. Anything other than 100% anticipation, I mean, you're looking at, even with a genetic predisposition, you're looking at a risk factor, but not a guaranteed outcome. Okay, the guaranteed outcome is more about things like infections and toxins. And I think it's about us as a crew moving diseases from an unclear, untenable situation into a, let's look at the underlying infections, let's understand the role that they're playing in these symptoms, let's come up with a strategy to tackle them. And going back to the person I was telling you about, Tony, 2 years of combination therapies by IV did not move the needle. So what I would say as far as infections, we very definitely are not looking one-dimensionally at the kind of basic infections that I think existed, well, before the advent of antibiotics and antivirals, right before all these super bugs from all of these modifications, oftentimes resulting from treatments. And so I would say treating infections is about understanding the priorities, getting really clear in your mind, understanding from a clinical point of view what different infections look like, making sure you're moving in the right order, and making sure that you're comprehensive. But it doesn't change the fact that ultimately we are routinely seeing people with chronic low-level infections and not necessarily recognizing the role that they are playing in existing or soon to be chronic diseases or cancers. The line at the bottom, so using Epstein-Barr as an example, and Epstein-Barr for me and this slide is only one example, but for me it's a pretty reasonable one, and the reason, the estimate is between 90 and 100% of humans have Epstein-Barr. Look at this last line. So this is actually coming out of a 2018 article that has now been rephrased and republished many, many times. They're describing the role that Epstein-Barr plays as a causal link for lupus, multiple sclerosis, rheumatoid arthritis, juvenile idiopathic arthritis, inflammatory bowel disease, celiac, type 1 diabetes. Diseases that I'm not sure anybody, or certainly I did not look at these diseases and wonder if there was, for example, a viral component to them. At no point did I think type 1 diabetes could be related to a virus, or specifically Epstein-Barr. So it changes, again, kind of this black box of diseases that we don't know and we don't understand, and so we cannot effectively treat or manage them. And it puts these diseases instead into a new place where we can clearly understand, we can quantify them by looking at the infections. We can look at certain environmental triggers, chemicals. We can determine who is replicating, oftentimes based on them, and we can find solutions, because we're not just stuck with old school options that at this point don't have the likelihood of success that we're looking for. Statement on the bottom. The conclusion. AFib appears to be caused by an EBV inflammatory process. Okay, my question, hands up. Everybody in the room went into this thinking, oh, Epstein-Barr, I know that virus. It's the primary cause of atrial fib. Anybody thought that? Okay, again, you guys know already, what I'm trying to make really clear, we are looking at infections that largely control health and longevity. But we've been living with them so long medically, I'm not sure that we looked at them from that vantage point, which is what's allowing lots of people to continue having these infections and chronic reactivations, ultimately leading to, from the slide before this one, a bunch of conditions that we're routinely seeing but don't necessarily know how to treat. Oh, I had a slide over here. I had a little bit of a slide problem this morning. I had a slide over here that I guess wound up coming back out, looking at the role of COVID in Alzheimer's disease. I'm saying that now I'm wondering, did I just change my slides around so it's afterwards? Okay, I put a pin in that. Everybody holds that thought. If it doesn't come after this slide, I'll give you the explanation. Lyme and coinfection. So if the slide before this was Epstein-Barr, and Epstein-Barr for me is not a specific infection that I want to bring to your attention. Instead, showing you that slide is a representation of herpes viruses and the role that herpes viruses oftentimes play in chronic diseases. Separate from that, so now just looking at what are common ailments, common infections that a majority of people have. So again, thinking about herpetic viruses, 90 to 100%. Right? Talking about Lyme, not only is it common, but increasing in prevalence. So we're looking at infections, again, that oftentimes are overlooked or perhaps not getting the degree of respect that they deserve from a treatment approach when it comes to understanding the underlying culprits behind a number of conditions that we're dealing with. On Lyme and co-infections, these are very hard to treat infections. Let's go over in more detail the type of testing. I think the conversations tomorrow are really going to be talking about testing very specifically. I don't think for us today that's our objective, although I don't mind going through it in the question and answers. My goal, again, is to give you, I think, a broader brush stroke on the role of infections in diseases that are oftentimes overlooked, the role of these infections specifically in neurodegenerative diseases, and how to get clear on types of testing is kind of a general concept, and types of protocols. And so just know Lyme and Lyme co-infections play a significant role oftentimes in neurodegenerative diseases. One of the more common questions that I'll ask folks, their hobbies. So I'll start out with an understanding of where'd you grow up and what's the family history and have you had any tick bites? And then I'll move into hobbies like camping and fishing. And then, depending on symptoms, I will very definitely run a comprehensive panel that includes Lyme, the co-infections for Lyme, the herpetic infections. I'll add zoster into that mix because it's rarely included. And I'll look for a host of parasites as well. Your question for me would be, out of the folks that I've seen for motor neuron disease, and just to kind of give you an idea, worldwide, BodyScience, outside of an academic center, we are the largest ALS center at this point worldwide. And the number of folks that we see outside of ALS for Alzheimer's, Parkinson's is very, very high. And so the question that you would have, how often are we seeing positive IgM titers for Lyme or Lyme co-infections in these folks? And the answer is over 70% of the time. So if you're trying to treat neurodegenerative diseases, well, I guess two really important points to make. One, they respond well to treatment. But two, the treatment may not be what you're thinking initially. The treatment may be infection focused. And going back to the conversations this morning, there was a question about, for example, homocysteine, measuring inflammatory markers, looking at the cell, putting in antioxidants. I think all those things are absolutely warranted. It does not change the fact that the cell is making the determination as to whether it wants to make antioxidants or it wants to make oxidants. So certainly from an IV perspective or a medication perspective, we can encourage the cell to go in a different direction. We could support the cell. If the cell's already making antioxidants, we could infuse in additional antioxidants. If the cell is trying to be oxidative, right, we could infuse in oxidative substances. We were talking about vitamin C earlier. Lower levels, antioxidant, higher levels, oxidant, right, and a lot of other chemicals kind of in a similar fashion. The question is, what if the cell could take on that role? What if the cell could make the antioxidants that it needs? Or to say it differently, why are these cells so pro-inflammatory? Whether they are cancer cells, whether they are cells as part of a chronic disease, what is making this inflammatory cascade? And so everybody here, I think, is already aware. I mean, you're looking at a nuclear factor in the cell, right? So the nucleus is going to dictate the role of the cell moving forward. And the cell is either going to build and repair or go out and kill. So nuclear factor 2, make a bunch of antioxidants. Nuclear factor kappa B, make a bunch of oxidants. Okay, so when you're thinking in the question earlier about things like interleukins 2 and 4, right, is the luxury, vitamin C is the luxury of a cell that feels happy and comfortable. And then by comparison, interleukins 6 and 8, tumor necrosis factor, the inflammatory proteins that we know, whether it's homocysteine and the question about methionine, in which direction methionine is going to move, right? Whether it's going to become homocysteine and stay over there, whether the cell wants to make inflammation through intention, that's going to be a nuclear factor. You guys know already, kappa B. And the question is, what's the easiest way to turn it on? A bunch of infections, right? So then we've got the two options. Option 1, modulate the cell by removing the things that is forcing it to make inflammation by going after the infections. Or wait for the cell to be stuck in a situation where its only option is to create oxidants in order to try and kill off whatever its infections or chemicals, in which case now a lot of the therapies that you're forced to use are therapies to try and control the inflammatory cascade. But controlling the infections, knowing that they're a large part of why that inflammatory sequence turned on, for me, is an easier, faster way than afterwards trying to mop up all the oxidating or oxidizing agents. Okay, so my message with Lyme, again, I know tomorrow's conversation's really going to go into the specifics of Lyme. The important part, I think, Lyme is becoming more and more prevalent. And Lyme is doing something very funny as kind of a primary infection. You know, it can weaken the immune system, and does. And by doing that, it allows opportunistic infections to reactivate. And it looks to be the reactivation of those opportunistic infections, right? The 90 to 100% of us as humans that have these low-level viral infections, just as one example, it's things like Lyme that come on board and create such a disturbance and such a confusion in the immune system that opportunistic infections, whether they are viral, parasitic, fungal, but they're going to come out. And so if you are not controlling the primary infections, you can expect to have limited control over the opportunistics. And just talking for a minute about sequence, if your objective is to go after a herpetic or anything else that's opportunistic, and you try and do that before going after the primary, it is not likely that you will keep that opportunistic infection in remission. As long as there is something that is destroying and distracting the immune system and impacting immune surveillance, these other low-level chronic infections will use that opportunity to cycle. And each cycle that they have, they will make modifications to the DNA that limit the immune surveillance from that point forward. Going back to COVID, not only did it give us, I think, a better understanding of immunology, but it allowed us to see on a planet-wide level what it looks like to have a primary infection that is so damaging to the antiviral cells of the body that you can see massive reactivations for years of herpetic infections, and the long haul or long-term consequences largely resulting from the herpetic reactivations. And so the question is not whether we all have these infections. The question is, can we control them? The idea of an immune system that declines starting around age 50 and certainly by the age of 60, here's a question, I think. You know, the lifespan is expected to be 120. If that's the case, how come we're all kind of stuck around 80? What's the difference? And so again, you are looking at, and I'll go back to the idea of AFib. That's crazy. It's a crazy concept that we're not looking at an enlarged heart that's just happening as a result of aging and blood pressure changes, kind of the way we were all raised up. Instead, we really are looking at a virus that we could treat. And the question is, what if we treated it at young ages? Then would we eliminate the risk of AFib? Well, I would tell you, all the articles point in the direction of the answer to be yes. And that's why I'm saying I think we're all living with infections that lead to diseases that we've kind of come to terms with as commonplace. What if there's a different standard? And so what is kind of exciting, I know I said that at the beginning, but what's exciting is that we're around at a time where we have options that we did not have before. And so the idea of using something like an SOT to reprogram, to change the DNA, to change how the body is seeing these infections, to hand the control back over to the immune system, here's the question. If you have the option from an infection standpoint, you pick your infection. So whether you guys want to do parasites, whether you want to do fungal, whether you want to do viral or bacterial, you've got the one of two options. The body takes control, senses, uses what it knows, and annihilates this thing. Or you go a medical option, so anti before whatever you want to put next, antibiotic, antiviral, antifungal. Which one do you choose? You choose body, right? Body's smarter. It's infinitely smarter. It knows when to start and when to stop. Going back to oncology, right? The difference between chemotherapy and immunotherapy. Just straight eradication, which has limited long-term capabilities, versus immune awareness, immune activation, immune support. And so although the options for treating these infections in the past were limited, the idea that we can now re-regulate the body's ability to see them at the DNA level is a game changer. And it allows us, again, to get better management over diseases where 10 years ago, nobody would have thought that we could get control over. Okay, 2024 article. Prior to this article, there was very little consensus in the field of neurology or in the Academy of Neurology about the role of infections in neurodegenerative diseases, and that made things tough. Right? It's pretty tough to go after infections in things like Alzheimer's, Parkinson's, ALS, and MS when the general consensus from the field of neurology is that infections are not playing a role. However, that idea has been kind of walked back over the course of the last year, certainly. And so the proof that we were looking for, the consensus that everybody was waiting to hear, is now available. And in fact, more treatments like monoclonal antibodies and antiparasitics are finding their way into the treatment of neurodegenerative diseases as this concept becomes more and more clear. And just 2 weeks ago, there was a landmark study saying the same thing. Right, showing the role of these infections in these diseases. And again, imagine moving these diseases, if you look at every single one of them, I think we would agree, perhaps with the exception of MS, if we look at Alzheimer's, Parkinson's, and ALS, you, I imagine, would have expected that there were very few, if any, treatment options that you could use that would control disease. And so when I tell you, I routinely look at infections, treat infections, and we are, as a center, able to control progression, and we've seen multiple reversals across the board in these, it should, I don't know, make you feel, I guess, empowered, I think is the word I'm looking for, right? Because imagine, it gives us, again, new tools in our toolbox and a new way of looking at these things. Chronic reactivation. So the question, what's the difference between the fact that everybody has these infections and the folks that wind up with neurodegenerative diseases resulting from them, right? So if everybody has herpetics, maybe not everybody, but an overwhelming majority, right, has at least one herpetic, and a significant amount of the population, and a growing number of the population, that has a Lyme or co-infection to Lyme, how come, by comparison, the population of neurodegenerative conditions isn't higher? Now, it is significant, especially after COVID, there's been a major rise. I'll tell you where I think the difference is. So the goal is not necessarily to eliminate these infections. You may be successful at doing that, but it is likely that that person would then be re-inoculated shortly after. The question is, can you get control of them? And control is going to come down, in my estimation, to the idea of stopping the reactivation of these infections into something where they become inflammatory. So modulating the levels down, not necessarily to zero, but controlling them to the point where the immune system and immune surveillance can do the rest of the work. So the distinction, from my vantage point, between somebody that has inflammation and is going to develop neurodegenerative disease versus somebody that just has inflammation from these infections but may never get one of these chronic neurodegenerative illnesses, it is how often these infections are reactivating. And so for an average healthy adult, you expect reactivations a handful of times a year, 2 to 4 times in the year. The way that reactivations are explained in the world of neurodegenerative diseases, frequent, short duration. It means as short as 6 hours and as frequently as daily. The challenge in that situation, you just do not have enough time to repair, right? So neuroinflammation in itself, I don't think is unique. And anybody that was at the bar last night could probably agree with that fact. Right, so I mean, we're doing stuff all the time that's going to cause some degree of neuroinflammation. And I think bodies are pretty decent at controlling and resolving neuroinflammation. The challenge is if neuroinflammation becomes so persistent that in the absence of healing, you wind up with degenerative changes. And so again, controlling reactivation rate or reactivation load, moving somebody with reactivations, frequent short duration, into somebody that just has a handful of reactivations in the year now allows for the healing in between. So the objective of disease control in my mind, and the idea of using treatment strategies, it is to be able to control the amount of reactivation to a level where you're never going to get to the point of inflammation being so chronic that it becomes degenerative. And whether you look at this through the lens of neurodegeneration or any other degenerative process, right? Degeneration ultimately is oftentimes the result of chronic inflammation, and that chronic inflammation is commonly the result of these treatable infections. All right, so what do we want to do about this whole thing? Identify and prioritize infections becomes the biggest consideration over here. You're going to have to, I think, decide whether as an SOT provider, you want to be an administrator or somebody that manages care. As an administrator, you are the person that is putting in the SOT. It's not an especially difficult process. It's pretty fast, it's pretty easy, and in general, it's well tolerated, especially while they're in the office, because any kind of changes or side effects or herxing is commonly going to happen after the fact. So as the administrator, if you're the person that's just pushing the SOT in, that part is simple, but not effective. SOT is not a therapy, it's kind of a strategy, and it gets rolled up into a combined approach in order to be successful. You can use SOT as a standalone or monotherapy for me, I don't find that you get good control. So the two places that I commonly see errors on the SOT side, one, again, just trying to push it in and be done. No pre-treatment, no post-treatment, not really understanding what you're dealing with, just administering an SOT. And then number two, not understanding or not recognizing the order and having a strategy as far as which infections go first, when to retest, how to retreat. And what I would tell you, having learned it a couple of years ago, it's not an especially difficult process. So the reason I like a small number of slides, I think a bunch of slides feels scary and overwhelming. And then when I'm the one that's sitting, in a seat, it feels for me in the end like, holy cow, I like the idea, where do I even get started? What I would like to accomplish by the end of this conversation, the fact that infections are a need to understand component of disease that are treatable and manageable, and by doing that, you can manage diseases. And number two, SOTs are a fairly simple to understand and use process. And by adding something like this into the practice, it can change outcomes. Let me ask, just to kind of get a sense, how many folks that are in here have already been using SOTs for infections? All right, so you guys are going to have to look around because the light's a little blinding. I feel like it's probably around 60%. Okay. What I would tell you, and I'll throw this thing out there, this question for everybody. I would tell you I've never run into a problem. We put in so many SOTs, I've never run into a problem. Is there anybody in the room that has put in an SOT and run into a major, major problem? They're safe. They're safe and they're easy to use. Again, the key is the strategy. And the strategy is something that you can learn and is going to be beneficial because it's going to change not just your vantage point on these infections, but disease control and management as a whole. All right, testing and clinical judgment. So number one, comprehensive pathogen panel. I find oftentimes that the approach to identifying infections is not great enough. And so I have not found a good way to use LabCorp Quest, right, and use a couple of tests for a handful of variants of Lyme to understand what's going on. If I can't get all of my numbers up front, then I have no point of comparison. And so I'm going to look for the most comprehensive, and I'm going to look for titer levels, both IgG and IgM, to get a clear understanding of what I'm targeting. I don't dislike the idea of weighing proteins, so getting your kilodaltons, but antibodies for me is a good way to see what the immune system sees as a problem. We were having a big conversation last night about the benefits and the limitation of testing, and the fact that oftentimes, over time, you may see new infections. Remember, the limitation of these tests, it's not an accuracy problem, but it is the fact that you're looking at a test that is seeing what the body is seeing at that moment. If there is not a reactivation, you are not going to see an elevated antibody titer level. That does not mean the infection may not be present. And so you may find as you are effectively treating infections that others, either because they weren't as big a priority for the immune system before you moved some of the key infections out of the way, or because new infections are activating with the intention oftentimes of trying to decrease immune surveillance so that the primary infection can kind of regain its position over there. And so do know the test, of course, is a snapshot of what's going on, and the limitation is infections that are routinely reactivating and then going into more of a dormant state, lytic and then latent. Antigen versus antibody. So I added antigen testing in about 2 years ago. Here was my question and my concern just looking at antibodies, right? Is there a risk of autoimmune? Is there a risk of cross-reactivity? So in other words, am I seeing antibodies to a certain infection, but only because of cross-reactivity? So the real bottom line is the immune system is building antibodies, but to something else. And so although antibodies have a degree of sensitivity and specificity, you are, of course, not looking at the infection. You are looking at the body's vantage point of what it believes it's seeing. So the goal of the immune system, go find infections. What's the goal of the infection? Evade the immune system. Okay, it can make for some wackiness, would be my scientific term, when it comes to antibodies and antibody titers and how titers are changing. And so having an antigen load so that you can actually see the proteins from the infection can oftentimes help. And certainly the time that I'll always run an antigen is if I've treated something and I continue to see a titer level elevation in spite of seeing clinical improvement. That, for me, starts to become a picture of a dysregulating immune system, which is not an SOT approach, meaning I'm not trying to kill stuff. I'm not trying to build an immune system towards that. I'm now trying to move to the strategy of controlling the immune system. Immune function and immune markers. So just discussing very briefly, the inflammatory cytokines, that becomes important. I'll normally do a lymphocyte map. So I'll look at the different breakout of cytotoxics versus helpers. I'll take a look and kind of get a sense of where helper 17 fits into that mix as far as modulating. And just talking about timing for SOT, I'm careful. The same way as if I was inoculating somebody for anything else, I would get a read on their lymphocytes. The conversation earlier today was this oftentimes lower normal white cell count in folks that have these chronic infections. And so the place that we want to see people, 9,000, 10,000, but the place that we commonly see folks that are chronically ill or that have these chronic infections, 4,000, 5,000, 6,000. And so using that to determine if it's a good day for an SOT is not, in my mind, a good way of doing it because they chronically have this low level, this exhausted population of white cells. But if you do run lymphocytes and you see a body that is limited as far as its immune capabilities, that for me is typically not the time that I'm going to look to put in an SOT. And so I might schedule somebody to come on in, but if they're suggestive of a reactivation at that time, if they come in and they just feel lousy, we'll normally wait it for at least another week. Toxins to determine replication. So when you're seeing all these infections, it feels like that, right? A bunch of infections. And the question, which ones are really linking to the diseases that you're trying to correct, and which ones are there as almost incidental findings, right? Large numbers of people have a lot of these infections. Which ones are causing the problems and which ones are not? There was a conversation earlier in the day about the cofactors that are used for replication of certain infections. And so I don't dislike a heavy metal panel. I'll normally do a urine 24-hour looking at heavy metals in order to determine if zoster's around, you'd expect to see at least some increase in arsenic. Right? If herpes simplex 1 is around, you'd normally expect to see a little bit of an elevation in things like mercury and cadmium. Right? For a lot of the Lyme co-infections, you're normally going to see that increase in manganese and zinc. And so just know it's not just the fact that you got to learn every one of these infections, it's that you can kind of put the pieces together. Again, I don't want to make this feel so difficult that it feels unapproachable. I don't think you have to have all of that from the very beginning. But I do think if when you are looking to interpret some of your labs and prioritize your infection, so your first group, from my standpoint, is always going to be your primaries, that's going to be Lyme. How you prioritize afterwards may be a function of running other tests and getting a better understanding of what you want to actually prioritize, who's replicating, right? High iron, herpetics can't move without a bunch of iron, right? The other thing as far as toxins, just know there are certain toxins that are becoming ubiquitous at this point. We were talking last night about fluorinated compounds and the role of fluorinated compounds, perfluorates, to really damage an immune system. And so if you have folks that have an environment filled with a lot of toxins, it's going to be hard to stabilize them because those toxins are going to continue to damage or disable the immune system, allowing these opportunistic infections to come up. So I'll always talk to the people that I'm working with about getting their environment under control. I will definitely run those tests, but here's what I would say. Although I'm routinely going to look at gut health, or what are the other things that we run as functional folks? Nutritional panel. We were talking earlier about SIBO. At no point do I think that by running that panel of functional tests and not addressing infections, do I feel like I'm going to get disease under control? I can, occasionally, if our objective as a crew is to get better outcomes more frequently in the shortest period of time, then I don't think it's going to be the way that we were trained from a functional standpoint about 10, 15 years ago, run a bunch of functional tests and then try and get everything fixed, because I don't imagine I'm the only one. I guess I could be, but I don't think I'm the only one where I've already tried that, and sometimes I have a great response, and sometimes I don't. And so the question is, what's the missing factor? Right? And what allows those same problems to show up again another year later? And so the infection component becomes as important, if not more important, than moving around those other pieces that we've all learned as functional and important. So we can measure heavy metals, we can measure environmental toxins, we can look at gut function, still going back to nuclear factors. What does the cell want to do? If the cell is bombarded with infections, it is going to be pro-inflammatory. And even if we try and fix a gut, as an example, if the cells are bombarded with infections, ultimately you are likely going to wind up back in a pro-inflammatory state. Okay, so the kill versus immune education. I know we talked about this, just kind of looking at it again, and now really introducing SOTs as a therapy. So kill strategy versus immune. Again, oncology, they already played this game, right, and made a massive move in the direction of the immune vote. Right? Because imagine, prior to about 2000, nobody was really trying to enlist the immune in chemotherapy. And in fact, if you think about where we were all 20 years ago, it was the opposite, right? A steroid-focused approach to try and reduce the immune system's awareness and surveillance. All recognizing now that recruiting the immune system to allow for better recognition of these infections gives us much better outcomes. And that's true in oncology, and it's true in functional, it's true in any type of degenerative disease, neurodegenerative or otherwise. So yeah, I mean, we've all been there, done that. Anybody in this room that has not tried a strategy of antibiotics or antivirals for a bacterial or viral infection, right? We've all tried it, and they are effective at simplistic infections. But the kinds of infections that we're talking about right now are complex combinations. They are superbugs, they are persisters and resistors, largely because, I imagine, the strategy that has been taken for so long, which is more of a short-term strategy of kill. It turns out that that kill strategy may not have been so great at eradicating bugs, but holy cow, it made them really smart. And now, as a result, we're dealing with these complex new generation combinations. And so we're not trying to see, is there one infection, can we go after this and resolve symptoms? We're trying to understand at the beginning, what are the combination of infections, and then how do we strategically want to go after them? Which infections first? So we discussed already, we'll go primary. If somebody has a tick-borne infection, that's always going to be the starting point. Primary for me is whatever can damage the immune system the most. The immune damaging agent, and let's say it's not Lyme, let's say it is somebody with well water and a chemical in that well that's causing immune problems. The primary is whatever is damaging the immune, because the opportunistics are really just doing their job. They're waiting for the immune function and surveillance to be low enough that they can come out and cripple it further. So going and identifying who is causing the most damage to the immune system becomes priority number one. And then orchestrating a roadmap as far as the remaining is what becomes important. Okay, we know this already, persisters versus pre and post treatment. Okay, here is my strategy. I typically like when folks come in for 5 days. I know that that's not always possible. It goes back to administration or management. Administration, somebody just comes in and you put in an SOT. For me, I like a 5-day treatment strategy if patients can come on in, and the majority of ours typically do. I'll normally situate an SOT in the middle. My first 2 days, what I'm gonna do, I'm going to improve and shore up my heat shock proteins, right? We are about to put an infection on notice that we know it's secret sauce. The idea that it's going to roll over and play dead is not what's going to happen, or at least in my experience, that is not what's going to happen. And so now we are looking at somebody with a white cell count that is an army down to about 5,000 and exhausted. You let this genie out of this box, I think it's a lamp. I'm not sure who comes out of a box. It's a genie in a lamp. If you do let this genie out of this lamp without controlling the immune system ahead of time and without making sure heat shock proteins are where they belong, you can run into some real problems. And so butyrate for me is a pretty good way to improve heat shock protein 70, so get some mitochondrial control. Interestingly, the antihypertensive terazosin, of course, if somebody is hypotensive, you can't use it, but it's been already shown to increase stress granules in the cell. Right? So I'm going to look for my first 2 days to improve cellular health, cellular function. After the SOT goes in, I'm going to now look to be able to supply the immune system with as many ingredients as it's going to need to manage that infection. The ingredients that we already know, Myers cocktail style, right? And in between SOTs, I'm going to use the kinds of things that we talked about this morning, artemisinin, curcumin. In my office, we're going to use pretty much everything IV. But I'm going to look to get control over those infections. I'm not going to look to control them before I put the SOT in, because now you can't sense the infection. I'm not going to look to do it immediately after, because now, again, the SOT is going to be limited to its ability to find and destroy, the instructions to find and destroy. But midway, I'm going to look to do that. And from a timing standpoint, it depends usually on what I'm treating. If I'm working on Lyme and Lyme co-infections, I'll wait 4 weeks. The reason, guideline is 7 days. I can tell you when I first started, I did not recognize at 7 days some symptoms suggesting that the immune system did not have good control over those infections. In Lyme in particular, I think we know things like depression and anxiety are common, but on the clinical side, often overlooked. What happened was I had somebody in week 3 that was crying all the time, but there was really no reason for it and didn't have a history of depression. It was ultimately a symptom of Lyme, and the fact that 3 weeks after the SOT, and we were looking at somebody that was still working on getting that infection under control. And so in my office, we wait 4 weeks on SOTs for Lyme and Lyme co-infections. When I'm treating Coxsackie, it has some unique things that it can do. So same thing, I'll wait that 4-week interval. For herpetics, I will go after them 7 days apart. Right, so if there's multiple herpetics that I'm looking to control, I'll figure out who is the shot caller in that. What do the symptoms look like, right, in order to kind of organize them. We're down to under 2 minutes, otherwise I'd go through them with us, but you're trying to get a sense of, is CMV the primary, and are you seeing it from a lymphocyte and antiviral standpoint? Is EBV the problem, and are you seeing it from massive fatigue all the time? Is zoster the problem, and so it's somebody that's routinely complaining of sciatica and neck pain, right? Is it herpes simplex 1, and so if they have visible symptoms, you're seeing reactivation in the form of cold sores. So the question becomes, can you kind of get a sense of which one? And again, you're treating in between with strategies to protect the cell, either because you're building up heat shock proteins, you're building up stress granules, you're reducing inflammation, so something like methylene blue, you're creating redox, so you're using an antioxidant that can be oxidative, resveratrol, trans-resveratrol is going to throw off its 2 hydroxyl rings, right? So it can do kind of both things. I'm commonly going to pre-treat with 600 milligrams IV alpha-lipoic acid. The reason? Holy cow, I want those insulin receptors to be pretty as can be. Right? I do not want this cell to be struggling with infection control and also to have any degree of insulin resistance. So trying to build up adiponectin to make sure that cell is healthy before I start going after infections, oftentimes for me becomes part of the pre-treatment. Just to let you know, light modulation for immune therapy is something that I use in my office. So sometimes it comes down to medication, and sometimes it comes down to technologies. So UVA, to just quiet down the immune system. UVC to contribute to the burn and just take things down. Red, green light. I normally do them by IV. Grounding meditation, we know already. I think as a crew we know there are certain things, and they're outside of the realm of medication, but they are integral to immune control. And so if I have somebody in a really high stress situation, I am not typically inclined to try and go after a bunch of infections. They're not getting a lot of sleep, they're super stressed, you already know that their immune system is likely in tatters. There are countless articles on the role of things like green tea, because of the EGCG, meditation, grounding, to improve T cell function and CD4 control. And so, along with the other things that we're talking about, I'll normally make sure to have a conversation with people about doing what they need to be doing at home. I like the idea and routinely use stem cells, fecal microbiota transplant. Let's talk about those two for just a quick minute, and then let's go over to high-resolution MRI. For stem cells, I use both exosomes and stem cells. The question we were talking about last night, for my neurodegenerative folks, stem cells, intrathecal. For anybody that's functional, it depends if I think I have disease control. So I'm trying to rebuild after the damage, so I have the infection under control, but there's still the post-infection damage. And without cleaning that up, you're still going to be limited to the amount of benefit that you're going to see. You may stop progression, but you're not going to see a reversal of symptoms unless there's something restorative. Stem cells are pretty decent for doing something like that. And so if I don't think I have control, but I'm looking at rapid progression, then for me, I'd rather go in the direction of exosomes. I can use them a lot more frequently. If I think I already have things under control and I'm trying to rebuild, stem cells that include progenitors and exosomes, that's normally where I'll be, either IV or, again, for neurodegenerative, intrathecal. Fecal microbiota transplant, because we were talking oncology this morning, there's plenty of articles describing FMT and its ability to increase sensitivity to chemotherapy or resensitize individuals to chemotherapy. From a microflora standpoint, I've tried all kinds of things to get a gut under control. The gut microflora is largely responsible for the substrates that are running the electron transport chain in the mitochondria. And so as just kind of a concept to get somebody healthy, doesn't mean that you have to do FMT, but if it's something that you're not doing currently or not familiar with, I think it's reasonable just to take a look at it, because we're talking today about, things to do differently or things to consider moving forward. High resolution MRI is where I'll end. And so what I would tell you, it's kind of a funny concept. The standard MRI Tesla rating is 1.5 or up to about 3. There are much higher resolutions, right? So 5, 7s, 9s. I did a lot of planning on surgical cases for Parkinson's patients for a long time. We only used 5 Tesla, and the reason is because you can't see anything on a 1.5 or 3. You could see gray, right? But you can't really see any of the nuclei in the brain. And the same is true when you're looking at neurodegenerative diseases. If you are a science geek, so that's kind of where I live. So if you geek out with me, then I would tell you looking at a higher resolution picture is a game changer. So imagine what's really tough is not knowing where you are in a brain, not knowing exactly where the inflammation is, or having an MRI that has been run in order to rule out strokes, bleeds, and MS, but you still can't see what you're doing. A 5 Tesla starts really getting clear images, and different infections have different neighborhoods. The same kind of dermatome approach that is true for zoster holds true actually in the brain for different kinds of infections. And so if you do have the opportunity, I don't use contrast, I recognize the limitation on the picture, but I still don't like the heavy metals from it. Using a 5 or 7 Tesla, again, if your focus is neurodegenerative, can be a real game changer. I'm way past time. I'd like to take questions, but I think I'm too far off time to be able to do that. Somebody's going to tell me.
You can take maybe 2 questions or
all right.
maybe 3.
I could take 2 questions.
I've got one already queued up for you over here.
All right.
As you were flying at 5 million feet high and 60 miles an hour past my brain, did I understand you equated neck pains and lower back pain to herpes zoster?
It can be, very definitely. Herpetics, you're looking at the ganglion, and you're looking at levels in the spine. You'll know them more easily if you kind of chase out the dermatome. I have somebody, ALS, zoster is in the mix. I know it because we treated it and we got really good control. the long and short. He's S1, and the way we knew it was atrophy. So a history of sciatica and foot drop, first of all. That's S1. And then the amount of atrophy, predictably, was on that same dermatome. So he had not just dropped foot, but calf involvement, lateral glute involvement. And so when you're looking at a level of the spine, an infection over there, and you can see a clear dermatome associated with that, then you should suspect zoster. And outside of sciatic compression, being, of course, the number one cause of sciatica, zoster is like number 2. It is a common cause of foot drop. So again, just kind of putting personalities on these infections, right? They're infections that we all know, we've all heard about them, we all briefly learned about them, but most of us have never really seen them as far as their personality and what they do. And so whether you're talking about lower spine or neck, I mean, herpes simplex 1 is almost always going to be in the C-spine. Herpes simplex 2 is almost always going to be at the base of the spine. When I see somebody and they have ALS and they have lower limb involvement as their first symptom, and it's almost exclusively lower limb, it is highly suspicious for something at the base of the spine. And then I'm going to start looking for things that like the base of the spine as a neighborhood. The model is already out there. We know it with things like Parkinson's. So I'm not sure if everybody's aware, but there's been a lot of discussion and proof behind the role of infections in Parkinson's over the course of the last 6 months. So what was the thought of pesticide, and I recognize the role that pesticides play, but infections are playing a major role, right? So much so that a monoclonal antibody is being evaluated for Parkinson's. I mean, you think about Parkinson's, you are looking at a unique predilection towards the substantia nigra that's going to ultimately impact the subthalamic nucleus and the globus pallidus, but it likes the substantia nigra. It's going to go after the substantia nigra. You think again about Alzheimer's, and you just saw the slide on the infections related to Alzheimer's. You're looking at infections that like the amygdala and the hippocampus, right? So these kinds of infections have preferences for nuclei in the brain and locations in the spine, and oftentimes looking at the roadmap of where symptoms started and how they progressed will give you a clear indication on the infections that you're chasing down.
Excellent. That is amazing. Thank you.
Do we have one more?
Yeah, so you got time for one more.
I've been shocked by how many positive PCRs for EBV and the early antigens. So having results with the SOTs for EBV, my question is, I'm not far enough out to see the resolution or expecting the resolution. I know this also just starts and stops anyhow on its own. So my question for you is, how far out are you following them test-wise? How many SOTs for the different viruses? Is this an ongoing? Are you going by symptoms or are you going by lab testing?
Okay, so everybody has the question. It was specific to EBV, but I know you're talking about just infections in general. To just delineate EBV proteins, we know that EA, early antigen, is not necessarily going to cause long-term consequences, although you can be looking at reactivations, but EBNA1, right, is what everybody has already isolated as the primary culprit for inflammation. VCA is right behind it. And so as far as how I'm looking to eradicate infections, if I'm unclear, and to the exact point that you're making, you get antibodies and you can't tell, is this almost an immune system that can't turn itself off, or are we looking at active infection? That is almost always the time that I'm going to look for antigen. If I see elevated antibody titers, but I don't see any antigen, I expect that EBV is not really the problem.
Okay.
Oh, forgive me. So antigen is, an early antigen is still an antibody test. Okay, but separate from testing antibodies, so I know we know this, just kind of thinking about the Y-shaped protein, but the antibody is the body's response to the immune system. So of course it's limited. Is the body really seeing what it thinks it's seeing? An antigen from the infection itself is the measure of the protein from the infection. So there are multiple labs. if you'd like, I'll give you kind of the list of the stuff that I use. I'm happy to, guys. I'm happy to provide whatever I have. I'm happy to share with you guys. I think I put over there collaboration. I'm a big fan of collaboration. I think it's how we're going to solve these problems. I think they're super solvable, and I think they're solvable in our time, and now it's going to come down to can we share information to get them to that point. So I'm happy to give you guys the labs that I use. I use an antigen lab that's over in Germany. I used to use one that was here in the US, but they didn't include zoster, and that for me was a problem. Okay? All right.
Wow. Thank you, Amy, for those insights and strategies on using SOT with neurodegenerative diseases.